Alright, Ackley 168 to 171, risk for bleeding. Uh, Definition: at risk for a decrease, at risk for a decrease in blood volume that may compromise health. Risk factors: aneurysm, circumcision, deficient knowledge, disseminated intravascular coagulopathy. History of falls. Gastrointestinal disorders, e.g., gastric ulcer disease, polyps, varices. Impaired liver function, e.g., cirrhosis, hepatitis. Inherent coagulotherapies, e.g., thrombocytopenia. Postpartum complications, e.g., uterine atony, retained placenta. Pregnancy-related complications, e.g., placenta previa, molar pregnancy, abruption placenta. Trauma, treatment-related side effects, e.g., surgery, medications, administration of platelet-deficient blood products, chemotherapy. Nursing outcomes classification. Suggested NOC outcomes: blood loss severity, blood coagulation, circulation status, knowledge, cancer management, fetal status, antepartum, intrapartum, maternal status, antepartum, intrapartum, postpartum, post-procedure recovery, physical injury severity, tissue perfusion, cellular and vital signs. Okay. Example NOC outcomes with indicators: blood loss severity as evidenced by visible blood loss, hematuria, post-surgical bleeding, decreased systolic blood pressure, decreased diastolic blood pressure, anxiety, increased apical heart rate. Rate each indicator of blood loss severity. Okay, never mind. Maternal status: postpartum as evidenced by the following indications: blood pressure, apical rate, and uterine fundal height, lochia amount, lochia color, hemoglobin. Client outcomes. Client will, in specified time frame, maintain stable vital signs with minimal blood loss, explain actions can take if bleeding occurs. Nursing intervention classification. NIC. Suggested NIC interventions: bleeding precautions, post-anesthesia care, bleeding reduction, postpartum uterus, bleeding reduction, antepartum uterus, hemorrhage control, hypovolemia management. Example of NIC activities: post-anesthesia care, monitor oxygenation, monitor vital signs, monitor surgical site. Example of NIC activities: bleeding reduction, postpartum uterus, review obstetrical history for risk factors for postpartum hemorrhage, increase fundal massage, evaluate the bladder distension. Nursing interventions and rationales: review client history for increased bleeding risk. Anticipate an increased risk for bleeding if client has a personal or family history of bleeding, post-trauma or post-operative bleeding, or personally used antithrombolytics in the past 5 days. Routine INR PT preoperatively is not recommended. Clients with von Willebrand's disease, 1 to 2% of population, will need a short-term or long-term course of VWD/VIII or V8 or F8 prior to undergoing a surgical procedure to decrease the risk of bleeding. Clients with or without a history of gastrointestinal bleeding may be at increased risk for bleeding if they take selective serotonin reuptake inhibitors, such as fluoxetine, paroxetine, and citrulline. Monitor signs of bleeding in the urine, stool, sputum, vomitus. Watch for nosebleeds, any petechiae, purpura, or abnormal bruising. Disseminated intravascular coagulation, or DIC, is a critical disease state that requires prompt action to avert death. It often results from a systemic infection. Specific signs include petechiae, cyanosis of fingers and nose, and oozing of blood from 3 unrelated sites. The underlying cause must be treated quickly, along with maintaining hemostasis. Monitor laboratory tests that evaluate bleeding, including hemoglobin, hematocrit, INR, protime, also known as prothrombin time. Hemoglobin and hematocrit levels are late determinants of bleeding or hemorrhage. However, they provide more objective than visual assessment of blood loss. International Normalized Ratio, INR, and prothrombin time measure the effects of medication on the coagulation cascade and should be drawn at least 16 hours after the dose is administered. Implement safety precautions such as a falls prevention protocol for client who has identified falls risks, i.e. history of falls. On admission and as indicated, nurses should assess for fall risks factors that increase the incidence of bleeding. Check vital signs at frequent intervals. Watch for changes associated with bleeding, including increased heart rate, respiratory rate, and eventually decreased blood pressure. Take orthostatic blood pressure readings, lying, sitting, and standing. Watching for characteristic patterns of hypotension associated with fluid loss. Watch for tachycardia and recognize that it may indicate hypovolemia. Tachycardia in the post-anesthesia care unit, or PACU, may indicate dehydration, hypovolemia, anxiety, or inadequate pain management. Even though hemorrhage is not a common problem in PACU, the presence of occult bleeding should always be considered. Monitor medications for effects on increasing bleeding, including aspirin, NSAIDs, and SSRIs. These medications have an antiplatelet effect that can increase the risk of bleeding, particularly in a client who is at risk due to illness or medications. Safety guidelines for anticoagulant administration. Follow the approved protocol for anticoagulant administration, including the time of administration, use of prepackaged medications, and prefilled or premixed parenteral therapy as ordered. Laboratory tests to check before administration and symptoms to notice before administration. Anticoagulation therapy is complex and too frequently leads to adverse dry events. Defined protocols can decrease errors in administration. Before administering warfarin, check the INR, hold the medication, and notify the physician if the INR is outside of the recommended parameters. The target INR for warfarin should be between 2 and 3 for non-valvular atrial fibrillation, between 2.5 and 3.5 for valvular atrial fibrillation. The risk for bleeding increases substantially when the INR is greater than 4, and risk for thromboembolism increases when the INR is below 1.7. Even in the therapeutic ranges, clients have a 2% to 4% risk for bleeding that requires transfusion. A 15% adjustment in the dosage usually changes the level by 1 INR. Use a programmable infusion pump only for administration of an intravenous continuous heparin infusion. Notify the dietary department when the client is receiving warfarin. This is to ensure consistency in the amount of vitamin K in the diet. Give vitamin K orally or intravenously if needed as ordered. When the client's INR is greater than 5, it is recommended to give vitamin K rather than just holding the warfarin. Avoid giving IM or sub-Q or decreased chance of irregular absorption that can lead to warfarin resistance. Client family teaching and discharge planning. Safety standards. Educate clients and families about the anticoagulant medications, including when to take, how often to have lab tests, and precautions that should be followed. Give the client both verbal and written instructions. Educate clients about when and how they can restart their anticoagulant following surgery. Clients with a moderate to high risk of thromboembolism are treated to prevent thromboembolism rather than prevent bleeding. Clients with a low risk of thromboembolism are treated to prevent bleeding rather than to prevent thromboembolism. Generally, warfarin is resumed 12 to 24 hours after surgery at the previous dose. Therapeutic levels should be achieved in 6 to 12 days, with older, that is greater than 70, or obese clients taking a little longer. Provide clients with education. Provide clients with education, both oral and written, that meets the standards of client education health literacy. Clients with low health literacy skills need to be empowered through teach-back and show-back techniques to assure their self-care safety. Advise client to adopt safety practices about self-care activities. Shave with an electric razor, brush teeth with soft toothbrush, wipe with wet wipes after stooling. Carry bandages with you at all times. Avoid sports and activities that could increase your risk for falling. Wear a medical alert bracelet or necklace. Teach client who is taking an anti-thrombolytic medication to monitor the intake of foods, herbs, and dietary supplements. Foods high in vitamin K, e.g. spinach, broccoli, cauliflower, cabbage, can decrease the effect of the medication. Consistent intake of these foods rather than avoidance is preferred. Increased activity will decrease the effect of warfarin. Illness, including fever, diarrhea, poor nutrition, large amounts of alcohol, and herbal supplements such as ginkgo, garlic, ginseng, and omega-3 fatty acids, will increase the risk or the effect of warfarin. Postpartum risk for bleeding. Based on prenatal and past medical history, determine need for IV fluids, sites, blood products, additionally uterotonics prior to delivery. Uterine atony due to prolonged labor, multi-party general anesthesia, tocolytics, multiple gestation, abnormal placental implantation, and uterine fibroids increase the risk of bleeding during the postpartum period. Coagulopathies such as thrombocytopenia, von Willebrand's disease need to be identified prior to delivery whenever possible. Portal hypertension resulting in esophageal varices is a rare but dangerous risk. Assess fundal height and lochia amount every 15 minutes for the first hour after delivery, every 30 minutes in the second hour, and every 4 hours after that as needed. Support the uterus at the symphysis pubis and massage the fundus of the uterus until it is firm. You can do that. I ain't gonna do that. Vigorous massage and downward pressure should be avoided. Frequently assess for clinical signs and symptoms of blood loss, such as dizziness, fatigue, tachycardia, and hypotension. Blood loss is frequently underestimated, 500 milliliters for vaginal and 1,000 milliliters for cesarean deliveries. Postpartum hemorrhage, PPH, complicates up to 5% of live births in the United States. Early PPH occurs in the first 24 hours. Late PPH occurs 24 hours to 6 weeks postpartum and complicates 1% to 2% of all live births in the United States. Establish an emergency response process for PPH based on outcomes from a multi-hospital study. Postpartum hemorrhage occurred more frequently on the weekend than during the days. Administer uterotonic agents, e.g. oxytocin, at the birth of the anterior shoulder as ordered. Active management of the third stage of labor. Early cord clamping. Uterotonic agent with birth of shoulder and controlled contraction of the umbilical cord significantly decreases the risk of postpartum hemorrhage. Okay, interesting. Educate women about the increased risk of having abnormal placental implantation with cesarean delivery and the increased risk of antepartum or postpartum bleeding. The placenta tends to implant over a previous uterine scar. Okay, and that was risk for bleeding. On to pages 502 to 505. Risk for perioperative positioning injury. Definition: at risk for inadvertent anatomical and physical changes as a result of positioning or equipment used during an invasive/surgical procedure. Risk factors: disorientation, edema, emaciation, immobilization, muscle weakness, obesity, sensory/perceptual disturbances due to anesthesia. High pressure for short periods of time and low pressure for extended periods of time are risk factors for tissue injury. Knock, suggested knock outcomes, circulation status, immobility consequences, physiological joint movement, neurological status, respiratory status, risk control, sensory function, skeletal function, tissue integrity, skin and mucous membranes, and tissue perfusion, peripheral. Example of knock outcomes with indicators: tissue perfusion, peripheral, as evidenced by the following indicators: peripheral edema / localized extremity pain, skin breakdown, muscle cramps, peripheral pulses, numbness, tingling, necrosis. Client outcomes: client will specify time frame. Demonstrate unchanged skin condition with exception of the incision throughout the perioperative experience. Demonstrate resolution of redness of the skin at points of pressure within 30 minutes after pressure is eliminated. Will remain injury-free related to surgical positioning, including intact skin and absence of pain and or numbness associated with surgical positioning. Demonstrate unchanged or improved physical mobility from perioperative status. Demonstrate unchanged or improved cardiovascular and respiratory status from perioperative status. Demonstrate unchanged or improved peripheral sensory integrity from perioperative status. Maintain sense of privacy and dignity. NIC. Suggested NIC interventions: circulatory precautions, fall prevention, neurological monitoring, peripheral sensation management, positioning, intraoperative, pressure, ulcer prevention, risk identification, skin surveillance, and surgical precautions. Example: NIC activities, positioning, intraoperative. Use an adequate number of personnel to transfer patient, maintain client's proper body alignment. Nursing interventions and rationales. General interventions for any surgical client. Recognize that there is a new accountability for perioperative nurses in the need to maintain skin integrity. As a result of research and evidence-based practice, all nurses have been mandated to manage skin integrity. This includes perioperative RNs. It is difficult to ignore this mandate. Prevention of pressure ulcers. Identify clients at risk for pressure ulcers development so that cost-effective, evidence-based preventative measures can be instituted. All surgical clients are at risk for pressure ulcer development. A literature review showed that most pressure ulcers occur within several days after surgery, and this delay in presentation can contribute to the surgery being overlooked as the trigger event. One study stated that all surgical clients are at moderate to severe risk for pressure ulcer development. Recognize that clients undergoing cardiac surgical procedures are at increased risk of developing a pressure ulcer, especially below the waist or in the occiput area, or occiput, OCCIPUT area. In one study, 52.9% of all pressure ulcers occurred on the heels, and most of these clients underwent cardiac surgery. Use pressure-reducing devices and pressure-relieving mattresses as necessary to prevent ulcer formation. A randomized controlled study showed that using a viscoelastic polymer pad reduced pressure ulcer development by half in comparison to using a standard or OR mattress. Research studies have shown the following. Pressure ulcer occurrence decreases with the use of a fluid pressure-reducing mattress along with comprehensive staff education. The standard 2-inch thick operating room or OR table mattress significantly contributes to the development of pressure ulcers. Up to 38% of surgical clients developed pressure ulcers when using a standard OR mattress versus 7% when using a pressure-relieving mattress. Recognize that extended pressure on the scalp can cause localized alopecia postoperatively, little bald spot. Research shows that the likelihood of alopecia developing can be reduced if the head is repositioned every 30 minutes. Avoid using rolled towels and bolsters made using towels, sheets, etc., as they tend to produce high and inconsistent pressures. Special positioning devices are available for use that redistribute pressure. Okay. Avoid covering positioning devices as the material used to cover the device reduces the effectiveness of the positioning device. Avoid covering positioning devices. Okay. Excuse me. Recognize that the nurse must demonstrate knowledge of not only the equipment, but also anatomy and the application of physiological principles in order to properly position the client. Pre-planning ensures that the correct positioning devices are available and in good working condition, and that appropriate numbers of personnel are available to position the client safely and appropriately. A preoperative assessment should be completed to identify physical alterations that may require precautions for procedure-specific positioning. To identify specific procedural positioning needs, type of anesthesia, etc. Monitor pressure being applied to the client intraoperatively by staff, equipment, and/or instruments. An adequate clearance of 2 to 3 inches should be maintained in order to protect feet and protuberant parts from overbed tables, Mayo stands, and frames. Injury due to retraction and manipulation of tissue has been observed during pelvic procedures, femoral nerve injuries, as well as during hip surgery, sciatic nerve injuries, and head straps can cause facial nerve injury if too tight. Okay. Pad all bony prominences. Pressure over bony prominences causes blood vessel compression, which in turn diminishes the flow of oxygen and nutrients to the area, which eventually results in cell death. Recognize that reddened areas or areas injured by pressure should not be massaged. One research study showed that pressure ulcer incidence was reduced 38% in non-massaged versus massaged areas. Don't be massaging that bony prominence. Implement measures to prevent inadvertent hypothermia. Anesthesia can compromise perfusion by causing hypotension and hypothermia. When coupled with the client being immobile on a non-compliant surface for an extended time period, increases vulnerability for pressure ulcer development during surgery. Positioning the perioperative client. Ensure that linens on the OR table are free of wrinkles. Folds and creases in linen can cause pressure on the skin. Lock the OR table, cart, or bed and stabilize the mattress before transferring positioning of the client. Clients should be monitored when on the OR table at all times. Excuse me. Studies show that a lack of clear communication about who should be watching the client has contributed to falls. Lift rather than pull or slide the client when positioning to reduce the incidence of skin injury from shearing and or friction. Sliding or pulling the client can cause shearing force and or friction. Ensure that appropriate numbers of personnel are present to assist in positioning the client. Use of transfer devices and adequate staff when moving/positioning patients decreases frictional forces, tissue bruising, and pressure injury. A minimum of 2 people should assist an awake client to transfer from a cart/bed to the OR table. One person on the stretcher side to assist the client onto the OR table, and the second person on the far side of the OR table to prevent the client from falling off the table. A minimum of 4 persons are necessary when transferring/positioning an anesthetized, unconscious, obese, or weak client. Recognize that optimally, clients, especially those with a limited range of motion/mobility, should be asked to position themselves under the nurse's guidance before induction of anesthesia so that he or she can verify that a position of comfort has been obtained. Ensure nerves are protected by positioning extremities carefully. Improperly positioned arms, hands, shoulders, legs, or feet can lead to serious injury or paralysis. Avoid hyperextension of joints. Hyperextension of joints can cause postoperative pain and permanent injury to extremities. Use slow and smooth movements during position of clients. Slow movements allow the body time to adjust to circulatory and respiratory changes and also allow the staff to have better control of the client's body. Place a pillow under the back of the knees to relieve low back pressure. Flexing hips and knees aids in keeping the client in correct position and protects common perineal and tibial nerves. Pillows placed directly in the popliteal space can injure the perineal and tibial nerves. Okay. I just said put pillows under there. And then it said, don't put pillows in the popliteal space. Okay, that's just weird. Reassess the client after positioning and periodically during the procedure for maintenance of proper alignment and skin integrity. Changes in position can expose or injure body parts, e.g., shearing, friction, compression, that were originally protected, and the safety strap can shift and apply increased pressure. Monitor intraocular pressure when client is in prone or knee-chest position. Compression in perioperative central retinal artery occlusion can occur with pressure to the eyes. Position hips in proper alignment with knees flexed. Unaligned hips can cause pressure to the low back and hip joints. When strained, hips are prone to lumbar plexus damage. Position the arms extended on arm boards so that they do not extend beyond a 90-degree angle. Do not position arms at sides unless surgically necessary. Position at a less than 90-degree angle decreases the risk of stretching injury to the brachial plexus and possible compression or occlusion injury to the subclavian and axillary arteries. When positioning arms at sides is necessary, place the arms beneath the sheet and bring the sheet over the top of the arm, and then tuck the sheet beneath the mattress so the arm can't fall off the mattress and hang over the metal edge of the table where it is exposed to being leaned against by the surgical team. Prevent pooling of preparative solutions, blood, irrigation, urine, and feces. Moisture can predispose the patient to pressure ulcer development. Keep the client appropriately covered during the procedure. Reducing unnecessary exposure provides privacy and dignity for the client during positioning and also helps in the prevention of hypothermia. If the client is positioned in Trendelenburg/reverse Trendelenburg or with the head of the bed raised/lowered, every attempt should be made to lift the client for several seconds. prior to prepping and draping to allow the skin to realign itself. When raising or lowering the head of the bed or placing the client in Trendelenburg or reverse Trendelenburg position, gravity can cause the skeleton to be pulled, which in turn can lead to tearing, folding, and/or stretching of tissue. Recognize that the client's positioned in lithotomy position should be kept in this position for as short a time as possible. One research review suggests that the client's legs be removed from lithotomy position. Devices every 2 hours. One research review suggests that the client's legs be removed from lithotomy positioning devices every 2 hours if the procedure is expected to last 4 hours or longer. Position the client's legs parallel and uncrossed. Crossing the client's ankles and legs creates occlusive pressure on blood vessels and nerves that can lead to pressure necrosis and also place the client at risk for development of deep vein thrombosis. Maintain normal body alignment. Misalignment, flexion, extension, and rotation may cause muscle and nerve damage as well as airway interference. Pressure on the carotid sinus can cause arrhythmias, and restricted venous outflow can occur with extreme rotation of the head. When applying body supports and restraint straps, safety belt, apply loosely and secure over waist or mid-thigh at least 2 inches above knees, avoiding bony prominences by placing a blanket between the strap and the client. Belts positioned directly over the knees cause compression of the perineal nerve against the fibula. Check equipment to verify it is in good working order and is used according to manufacturer's instructions. Equipment that is working properly leads to client safety and aids in improved exposure of the surgical site. Many beds have a weight limit for safe use, therefore, it is necessary to check the equipment to ensure that it will tolerate the client's weight. A research review of 16 incidence reports found that 63% involved using positioning equipment with specific weight limits on clients above the specified weight limit. Assess the client's skin integrity immediately postoperatively. Assess and document document postoperative skin tissue integrity, focusing on areas with constant pressure during the procedure and limb function for nerve damage. Remove client jewelry before surgery because it can cause pressure injury, become entangled in bedding, or catch on equipment during transfer. Recognize that complete, concise, accurate documentation of client assessment and use of positioning devices is imperative. For information on specific positioning, supine, prone, lateral, lithotomy, Trendelenburg, reverse Trendelenburg, please refer to Phillips and F. blah blah blah. Okay, then on to 517 to 520. Deficient knowledge with the specifier. And there's independent and collaborative and evidence-based. Definition. There we go. Absence or deficiency of cognitive information related to a specific topic. Defining characteristics. Exaggerated behaviors, inaccurate follow-through of instruction, inaccurate performance of test, inappropriate behaviors, e.g. hysterical, hostile, agitated, apathetic, and verbalization of the problem. Related factors: cognitive limitation, information misinterpretation, lack of exposure, lack of interest in learning, lack of recall, unfamiliarity with information resources. Suggested knockout codes: knowledge, diet, disease, process, energy, conservation, health behavior, health resources, infection management, medication, personal safety, prescribed activities, substance use control, treatment procedures and treatment regimen. Example, outcome with indicators. Knowledge having to do with health behavior as evidenced by the following indicators: healthy nutritional practices and benefits of activity and exercise, safe use of prescription and non-prescription medication. Client outcomes. Client will specify specific time frame. Explain disease state, recognize need for medications, and understand treatments. Describe the rationale for therapy and treatment options. Incorporate knowledge of health regimen into lifestyle. State confidence in one's ability to manage health situation and remain in control of life. Demonstrate how to perform health-related procedures satisfactorily. List resources that can be used for more information or support after discharge. Suggested NIC interventions, teaching, disease process, individual learning facilitation. Examples: NIC activities, teaching, disease process. Discuss therapies, treatment options, describe rationale behind management therapy treatment recommendations. Nursing interventions and rationales. Consider the client's ability and readiness to learn, e.g. mental acuity, ability to see or hear, existing pain, emotional readiness, motivation, and previous knowledge when teaching clients. Each client is unique, and client motivation, beliefs, and expectations will influence learning. Learning readiness changes over time based upon situational, physical, and emotional changes. The nurse assumes the role of authority, guide, motivator, mentor, and consultant, depending on the learning readiness of the client. Assess personal context and meaning of illness, e.g. perceived change in lifestyle, financial concerns, cultural patterns, and lack of acceptance by peers or coworkers. Improved symptom management and client satisfaction were noted as a result of interventions that focused on the needs of the client and the meaning and perspective of their illness. Monitor how clients process information over time. Clients are unique in how they process information. Some clients will be more uncertain than others and may need more educational intervention over time. Use individualized approaches that support client priorities, preferences, and choice. Individualized educational interventions have a positive effect on client outcomes. Engage client as a partner in the educational process. A nursing approach that is collaborative and that uses encouragement and support to increase self-efficacy resulted in client satisfaction, empowerment, and confidence. Low literacy clients who were active and participated in the development of educational materials became more involved in the process of learning. Provide information to support self-efficacy, self-regulation, and self-management. Knowledge of disease management alone does not directly result in behavioral change. Enhancing self-efficacy and confidence in one's ability to problem solve and make decisions should be included in self-management education. Assess the client's literacy level when using written information. Healthcare professionals may overestimate reading or comprehension levels of their clients. Education for those with low literacy should be as least threatening as possible. Multiple educational strategies include picture, digital, and telephone follow-up have proven effective in reducing complications in those with chronic conditions. Provide visual aids to enhance learning. Visual aids such as picture and simple word captions have proven to be effective when used to highlight important information, especially when working with clients with low literacy. Consider coordinated, multifaceted methods of dispersing information. Coordinated efforts using a combination of written and verbal information, regular review, and a written action plan have proven beneficial for self-care behavioral change. Use coaching methods such as telephone follow-up to reinforce learning. Coaching clients using telephone follow-up by expert nurses and allied health care professionals has proven effective in improving symptom management, increasing self-efficacy, and increasing client satisfaction. Help the client appropriate follow-up resources for continuing information and support. Advocating for the client's participation using a community-based case management program has demonstrated improved clinical and financial outcomes for clients with complex chronic conditions. Consider using a problem-solving group educational program. Group care that uses a discovery and problem-solving approach and tailors learning to individual information needs has proven more effective than standard one-to-one teaching in empowering individuals. More intensive one-to-one attention may be needed for socially disadvantaged populations. Use computer and web-based methods as appropriate. Information dispersed as an interactive web-based method contributed to a greater behavioral changes, increased participation, and self-efficacy. However, the effectiveness for specific populations, such as disadvantaged populations, is unclear. Use teaching methods that reinforce learning and allow adequate time for mastery of content. Teaching strategies that focus on repetition, simplifying content, and stating rationale for the why of learning enhances adherence. Offering more than one educational session and longer face-to-face contact have been implicated in positive outcomes, especially for clients with low literacy. Use outreach and community educational intervention as appropriate. Use support groups, including community and lay educators, may be helpful, particularly for disadvantaged populations. Pediatric. Use family-centered approaches when teaching children and adolescents. Parents expressed a need to negotiate and participate with healthcare providers about decisions regarding the care of their children. Use educational strategies that are interactive and engaging for younger children and toddlers. Information transfer that is highly individualized and interactive is recommended. Provide a developmentally appropriate environment when addressing the health education needs of adolescents. Select communication strategies that are developmentally appropriate when providing information to children and adolescents and that take into consideration the uniqueness of the young person's physical condition, cognitive ability, perceived needs, and preferences. Geriatric. Involve older clients in setting their own goals and participating in the decision-making process, allowing senior clients to set goals that are meaningful to them and are realistic have demonstrated positive clinical outcomes. Adapt the teaching process for the physical constraints of the aging process, e.g. speak clearly, use a variety of audio-visual psychomotor methods, provide examples, and allow time for the client to repeat and review. Adults are capable of learning at any age. Age modifies, but does not inhibit learning. Ensure that the client uses necessary reading aids, e.g. eyeglasses, magnifying lenses, large print text, or hearing aids. Visual and hearing deficits require amplification or clarification of sensory input. Educating the older adult about healthcare information is affected by cognitive decline associated with the aging process. Use of cognitive resources, sensory input, processing speed, working memory, and inhibition must be assessed to assist the older adult in learning. The nurse must understand these resources to choose effective teaching strategies to use with older adults. Use printed material, videotapes, lists, diagrams, methods that clients can refer to at another time are recommended. Repeat and reinforce information during several brief sessions. Brief sessions focus attention on essential information. Older clients benefit from repeated follow-up sessions. Discuss healthy lifestyle changes that promote wellness for the older adult. Greater efforts must be made both to improve preventative care and enhance quality of life interventions for older people. Offer opportunities for practice of psychomotor skills. Older adults indicate a preference for hands-on learning. They learn with hands-on and through rehearsal when taught psychomotor skills. Refer elderly clients for post-discharge follow-up as they transition from hospital to home in regards to their treatment and medication regimens. Extended follow-up and social support may prevent collapse and readmissions in older vulnerable clients. Consider using technology, including interactive computer programs and other creative interventions, to dispense health education to older adults. Older adults will use technology based upon a decision-making process of costs versus benefits, regardless of previous positive or negative experience. Group support made available through interactive e-health programs may be helpful in dispersing information and providing social support. Creativity interventions have been shown to positively affect mental and physiological health indicators. Use of creative interventions such as art, poetry, and writing are useful interventions to help an older adult learn. Recent research indicates that creative interventions help to stimulate cognitive abilities in older adults. Multicultural and acknowledge racial ethnic differences at the onset of care. Show respect. Acknowledge racial ethnic differences. Show sensitivity and self-awareness to enhance communication and rapport and promote treatment outcomes. Assess for the influence of cultural beliefs, norms, and values on the client's knowledge base. Illness beliefs guide health behavior. Provide written health care information to clients with limited English proficiency in their native language. Clients with limited English proficiency were unable to understand routinely dispensed medication instructions written in English. Assess for cultural, ethnic, self-care practices. Folk and home remedies may interact with medications and treatment. Use teaching methods that are culturally sensitive and support client customs, values, and lifestyle. Educational programs that focus on the cultural content and not disease symptoms alone have proven to be more effective than generic education programs. Be aware of the potential influence of medical interpreters in information sharing and decision making, and of the possible difficulties for clients when using medical interpreters. Different categories of interpreters, e.g. trained, untrained, and professional, may influence how information is shared. Home care. All of the previously mentioned interventions are applicable to the home setting. Assess the client, family, learning needs, information needs, and current level of knowledge. Caregivers express a need for having their informational needs met. Monitor the appropriateness of using telehome health care as a teaching method for families. While clients report satisfaction with telehome health methods, they also express that they do not want to lose their personal contact. Encourage family and peer support. A partner-guided protocol that included integrated education and training of clients and partners, improved symptom management. There was also significant improvement in self-efficacy and caregiver strain. Assess for specific areas of learning that have the potential for strong emotional responses by the client or family caregiver, attending to physical care, and failing to assess for distress in clients and family caregivers can impact health outcomes and quality of life. Moving on to 865 to 869, urinary retention. Definition: incomplete emptying of the bladder. Defining characteristics: measured urinary residual greater than 150 to 250 milliliters, or 25% of total bladder capacity, voiding and post-micturition, LUTS, LUTS, slow stream, intermittency of stream, hesitancy of urination, post-void dribbling, feelings of incomplete bladder emptying, often accompanied by storage LUTS, urgency, day and nighttime voiding frequency, occasionally accompanied by overflow incontinence, dribbling, urine loss caused when intravascular pressure overwhelms the sphincter mechanism. Related factors: bladder outlet obstruction, benign prostate hyperplasia BPH, prostate cancer, prostatitis, acute prostatic congestion and inflammation after implantation of irradiated seeds, urethral stricture, bladder neck dyssynergia, bladder neck contraction, and detrusor striated sphincter dyssynergia, high tone pelvic floor muscle dysfunction, obstructing cystocele, urethral tumor, urethral polyp, posterior urethral valves, and postoperative complication. Deficient detrusor contraction strength, sacral level spinal lesions, cauda equina syndrome, peripheral polyneuropathies, herpes zoster or simplex affecting sacral nerve roots, injury or extensive surgery causing denervation of pelvic plexus, medication side effect, complication of illicit drug use, impaction of stool. Defining characteristics and related factors adapted from the work of Nanda. NOC suggested outcome, urinary elimination. Example NOC outcome with indicators: urinary elimination is as evidenced by the following indicators: empties bladder completely, absence of urinary leakage between catheterizations or containment of micturition by condom catheter and drainage bag, absence of UTI, which is negative leukocytes and bacterial growth negative or less than 100,000 CFU per ml. Client will specify time frame. Demonstrate consistent ability to urinate when desire to void is perceived or via timed schedule. Measured urinary residual volume is 200 to 250 mLs or 25% of total bladder capacity. Voided volume plus, that's the voided volume plus urinary residual volume. Experience correction or relief from voiding and post-void LUTS. Experience correction or alleviation of storage LUTS. Be free of upper urinary tract distress. Renal function remains sufficient. Febrile urinary infections are absent. Suggested NIC interventions: urinary catheterization, urinary retention care. Example NIC activities: urinary retention care, Perform a comprehensive urinary assessment focusing on incontinence, e.g. urinary output, urinary voiding pattern, cognitive function, and pre-existent urinary problems. Use the power of suggestion by running water or flushing toilet. Provide enough time for bladder emptying. Use double voiding technique. Nursing interventions and rationales. Obtain a focused urinary history emphasizing the character and duration of lower urinary tract symptoms. Query the client about episodes of acute urinary retention, complete inability to void, or chronic retention, documented elevated post-void residual volumes. Although the presence of obstructive or irritative lower urinary tract symptoms is not diagnostic of urinary retention, a focused nursing history can provide clues to the likely cause of retention and its management. Question the client concerning specific risk factors for urinary retention, including disorders affecting the sacral spinal cord, such as spinal cord injuries of vertebral levels T12 to L2, disc problems, cauda equina syndrome, and tabes dorsalis. Acute neurological injuries causing sudden loss of mobility, such as spinal shock or ischemic stroke. Metabolic disorders such as diabetes mellitus, chronic alcoholism, and related conditions associated with polyuria and peripheral polyneuropathy neuropathies. Herpetic infection involving the sacral skin and underlying spinal dermatomes. Heavy metal poisoning, lead, mercury, causing peripheral polyneuropathies. Advanced stage human immunodeficiency virus, HIV. Medications including antispasmodic / parasympatholytics, alpha-adrenergic agonists, antidepressants, sedatives, narcotics, psychotropic medication, illicit drugs. Recent surgery requiring general or spinal anesthesia. Vaginal delivery within the past 48 hours. Bowel elimination patterns, history of fecal impaction and copresis. Recent surgical procedures. Recent prostatic biopsy or brachytherapy therapy. Okay. Urinary retention is related to multiple factors affecting either detrusor contraction strength or urethral resistance to urinary outflow. Multiple factors in the surgical client are associated with an increased risk of postoperative urinary retention, including preoperative voiding difficulty, advanced age, total amount of fluid replacement during a 24-hour postoperative period, type of anesthesia, pain management medications, and route and level of medication administration. Perform a focused physical assessment or review results of a recent physical, including perineal skin integrity inspection, percussion and palpation of the lower abdomen for obvious bladder distension, a neurological examination including perineal skin sensations and the bulbocavernous reflex, the vaginal vault examination in women, and digital rectal examination in men. The physical assessment provides clues to the likely cause of urinary retention and its management. Determine the urinary residual volume by catheterizing the client immediately after urination or by obtaining a bladder ultrasound after micturition. Although catheterization provides the most accurate method to determine urinary residual volume, it is invasive. Produces discomfort and carries a risk of infection. Post-void bladder ultrasound performed by registered nurses provided reasonable estimates of post-void residual bladder volumes in clients treated in acute care and geriatric rehabilitation units. The results of the ultrasonic measurement changed nursing practice by 51% of instances, reducing unneeded catheterizations by 32%. Complete a bladder log including pattern of urine elimination, urine loss, if present, nocturia, and volume and type of fluids consumed for a period of 3 to 7 days. The bladder log provides an objective verification of urine elimination patterns and allows comparison of fluids consumed versus urinary output during a 24-hour period. Consult the physician concerning eliminating or altering medications suspected of producing or exacerbating urinary retention. Observational studies suggest that medications may play a role in approximately 10% of all cases of urinary retention. The most commonly implicated drug classes include antipsychotics, antidepressants, anticholinergic, respiratory agents, opioid analgesics, alpha adrenoceptor agonists, benzodiazepines, nonsteroidal anti-inflammatory drugs, antimuscarines, and calcium channel blockers. A whole bunch of them. Teach the client with mild to moderate obstructive symptoms to double void by urinating, resting in the bathroom for 3 to 5 minutes, and then trying again to urinate. Double voiding promotes more effective bladder evacuation by allowing the detrusor to contract initially and then rest and contract again. Teach the client with urinary retention and infrequent voiding to urinate by the clock. Timed or scheduled voiding may reduce urinary retention by preventing bladder overdistension. Advise the male client with urinary retention related to BPH to avoid risk factors associated with acute urinary retention as follows. Avoid over-the-counter cold remedies containing a decongestant, alpha-adrenic agonist, or antihistamines such as diphenhydramine, which has anticholinergic effects. Avoid taking over-the-counter dietary medications, frequently contain alpha-adrenergic agonists. Discuss voiding problems with a healthcare provider before beginning new prescription medications. After prolonged exposure to cool weather, warm the body before attempting to urinate. Avoid overfilling the bladder by regular urination patterns and refrain from excessive intake of alcohol. These modifiable factors predispose the client to acute urinary retention by overdistending the bladder and compromising detrusor contraction strength or by increasing outlet resistance. Teach the patient who is unable to void specific strategies to manage this potential medical emergency as follows. Attempt urination in complete privacy. Place the feet solidly on the floor. If unable to void using these strategies, take a warm sitz bath or shower and void, if possible, while still in the tub or shower. Drink a warm cup of caffeinated coffee or tea to stimulate the bladder, which may promote voiding. If unable to void within 6 hours, or if bladder distension is producing significant pain, seek urgent or emergency care. Attempting urination in complete privacy and placing the feet solidly on the floor help relax the pelvic muscles and may encourage voiding. Warm water also stimulates the bladder and may produce voiding. The cooling experienced by leaving the tub or shower may again inhibit the bladder. Remove the indwelling urethral catheter at midnight in the hospitalized client to reduce the risk of acute urinary retention. Removal of the indwelling catheters in clients undergoing urologic surgery at midnight offers several advantages to morning removal, including a larger initial voided volume and earlier hospital discharge with no increased risk for readmission compared with those undergoing morning removal. Consult the physician about bladder stimulation in the client with urinary retention caused by deficient detrusor contraction strength. High-frequency transvaginal electrical stimulation of the bladder neck has been shown to be beneficial in a small case series involving women with chronic urinary retention owing to deficient detrusor contraction strength. Perform sterile or clean intermittent catheterization as directed for clients with urinary retention. Clients managed with intermittent catheterization using clean technique had no more symptomatic UTI than those managed by intermittent catheterization using sterile technique. Okay. Teach the client with significant urinary retention to perform clean self-intermittent catheterizations as directed. Intermittent catheterizations allows regular, complete bladder evacuation without serious complications. Intermittent catheterization can be mastered by clients with mild cognitive dysfunction associated with neurological conditions such as multiple sclerosis, enabling them to maintain adequate bladder emptying without resorting to an indwelling catheter. Advise clients with indwelling catheters that bacteria in the urine is an almost universal finding after the catheter has remained in place for a period of 30 days or longer, and that only symptomatic infections warrant treatment. The long-term indwelling catheter is inevitably associated with bacterial colonization. Most bacteriuria does not produce significant infection, and attempts to eradicate bacteriuria often produce subsequent morbidity because resistant bacteria are encouraged to reproduce while more easily managed strains are eradicated. Intermittent catheterization was preferred in a rehabilitation setting because it improves client quality of life and diminishes the time required to recover spontaneous voiding with a post-void residual volume of less than 150 mLs. Use the following strategies to reduce the risk for catheter-associated UTIs whenever feasible. Insert the indwelling catheter only when indicated. Remove the indwelling catheter as soon as possible. Acute care facilities should institute a policy for regular review of the necessity of an indwelling catheter beginning 3 to 4 days after insertion. Insert a silver alloy catheter for short-term indwelling catheterization, less than 14 days. Maintain a closed drainage system whenever feasible. Regularly cleanse the urethral meatus with a gentle cleanser to remove apparent soiling. Change the long-term catheter every 4 weeks whenever possible. More frequent catheter changes should be reserved for clients who experience catheter incrustation and blockage. Place clients managed in an acute or long-term care facility with a catheter-associated UTI in a separate room from others managed by an indwelling catheter to reduce the risk of spreading the offending pathogen. Educate staff about the risks of catheter-associated UTIs and specific strategies to reduce this risk. These strategies are supported by sufficient evidence to recommend routine use. Strategies that lack sufficient evidence to support routine use include 1. Strict aseptic technique when replacing a long-term indwelling catheter. 2. Application of antimicrobial ointments during routine meatal care. 3. Application of antimicrobial ointments or creams to the urethral meatus. 4. Adding hydrogen peroxide or silver sulfadazine or slow-releasing silver ions to the catheter drainage bag. 5. Frequent drainage bag changes. Or 6. One-way catheter valves. Okay. Geriatric aggressively assesses elderly clients, particularly those with dribbling, urinary incontinence, UTI, and related conditions for urinary retention. Elderly women and men may experience urinary retention with a few or no apparent symptoms. A urinary residual volume and related assessments are necessary to determine the presence of retention in this population. Assess elderly clients for impaction when urinary retention is documented or suspected. Fecal impaction and urinary retention frequently coexist in elderly clients, and unless reversed, may lead to acute delirium, UTI, or renal insufficiency. Assess elderly male clients for retention related to prostatic enlargement, BPH, or prostate cancer. Prostate enlargement in elderly men increases the risk of acute and chronic urinary retention. Home care. The interventions listed previously may be adapted for home care use. Encourage the client to report any inability to void. Pathophysiological factors of urinary retention require follow-up. Maintain an up-to-date medical list. Evaluate side effect profiles for a risk of urinary retention. New medications or changes in dose may cause urinary retention. Refer the client for physician evaluation if urinary retention occurs. Identification of cause is important. Left untreated, urinary retention may lead to UTI or kidney failure. Client and family teaching and discharge planning. Teach techniques for intermittent catheterization, including use of clean rather than sterile technique, washing using soap and water or a microwave technique, and reuse of the catheter. Teach the client with an indwelling catheter to assess the tube for patency. Maintain the drainage system below the level of the symphysis pubis, and routinely cleanse the bedside bag. Teach the client with an indwelling catheter or undergoing intermittent catheterization the symptoms of a significant urinary infection, including hematuria, acute onset incontinence, dysuria, flank pain, or fever. Okay, that's Unit 1, Ackley.